Hello, my name is Hitomi Hosoya. I am a physician scientist at Cedars-Sinai Medical Center at Hematology and Cellular Therapy Group. Tomorrow, I'll be presenting our data looking at association with delayed neurotoxicity and CAR T-cell expansion. So CAR T-cell therapy has improved patients' clinical outcomes significantly in relapsed refractory multiple myeloma patients. However, it comes with significant toxicities. The toxicity include immediate toxicities such as cytokine release syndrome and ICANS neurotoxicity that you may see in a lot of clinical trial reports. And there's also intermediate toxicity that includes delayed neurotoxicity. Delayed neurotoxicity can occur after several weeks to months of the CAR T treatment, and patients can present with Bell's palsy or other cranial nerve palsy, sometimes peripheral neuropathy, and rare cases, and it's a very complicated symptoms, but can present as Parkinsonism-like syndrome, which is challenging to treat and may not be reversible. So for these reasons, delayed toxicity represents one of the key barriers for wider adoption of CAR T-cell therapy. So our group have looked at what is the association between CAR T expansion and more as a surrogate marker and more clinically applicable. We also look at the lymphocyte count, which we measure in blood tests routinely during CAR T therapy. We initially found that the peak expansion of CAR T or the peak lymphocyte levels is not associated with clinical efficacy after Cilta-Cel CAR T therapy. And this is a little bit different from other CAR T product we use for myeloma called Cilta-Cel. However, what we found that the peak CAR T level is significantly associated with neurotoxicity. This includes immediate neurotoxicity, the ICANS that I talked about, as well as delayed neurotoxicity. So patients who developed delayed neurotoxicity had significantly higher CAR T peak level compared to those who did not develop such toxicity. We also look at the lymphocyte count, and that also was true in the lymphocyte count peak levels. So those who developed delayed neurotoxicity had significantly higher lymphocyte count compared to those who did not develop such toxicities. We also look at the dynamics of the lymphocyte count during the CAR T therapy and found that the early rise of the lymphocyte count between days 7 and 12 after the CAR T infusion was significantly greater in those who developed delayed neurotoxicity compared to those who did not. So looking at using this observation, we try to identify a threshold at which we can identify patients at risk of developing delayed neurotoxicity based on lymphocyte count. By some statistical analysis, we found that the threshold of lymphocyte count of about 2,400 is a good cutoff to capture those patients who develop delayed neurotoxicity. If we look at Parkinsonism cases specifically, a threshold was a little bit higher at 3,900. So to be able to translate our findings into more clinical practice, we defined that ALC threshold above 3,000 or ALC threshold above 2,500 with a daily increase of more than twofold can effectively capture those patients who are at risk of delayed neurotoxicity. Based on this observation, we are now running a clinical observational study to see if we can mitigate the risk of delayed neurotoxicity by giving a prophylaxis therapy for those patients who have an elevated lymphocyte count. Thank you.